Hello, Clinic Review family. It's Dr. Sharon with Clinic Reviews. As you know, I am continuing to go through the National Council of State Boards of Nursing survey that they did with new grads. And today I'm going to be talking about, let me look at my notes here, the activities that require the highest clinical judgment. Okay, so they give out these 150 items. They ask new grads to rank them according to the highest frequency. How often are they doing things? The highest rated. I don't know exactly what that means, but they just were overall highest rated. They ask them the most applicable, so just very applicable to your area where you work. And then the last one was the highest clinical judgment relevance. So there's some activities that they felt required less clinical judgment than other things. These were the activities that required the highest clinical judgment. Y'all, these are things you have to get right in order to pass Nclex. Well, all of these activities, you have to get about 50% right. But these are probably ones that are going to be a little bit more difficult as far as requiring clinical judgment. Certainly not just straight knowledge. So the things that they identified as having the highest clinical judgment rating was recognize and respond to complications, monitor vital sign trends, and safe medication administration. So we certainly have seen recognize and respond to complications before. We've seen safe medication administration before, but monitoring vital sign trends is new. So I know we're doing a lot of the same topics, but these are things that you're going to see for sure, 100% for sure on your Nclex, and you need to be able to answer these questions. So let's go ahead and get started. Hello, Clinic Review family. It's Dr. Sharon with Clinic Reviews, the home of the very best Nclex review in the entire universe, in my opinion. Thank you for tuning in. Today, we're going to be talking about, as I told you, the highest clinical relevance activities according to the National Council of State Boards of Nursing survey with new grads. These are going to be reflected on the 2026 Nclex. However, the activities are there's very little difference between the survey they did in 24 and the survey they did in 21 or maybe 20. So anyway, there's not much difference. So you're going to see these if you're taking the Nclex now or if you're going to take it in 2026. So Mark Klimek is the GOAT of Nclex prep. He's taught me everything I know. I do recommend, if you haven't seen it, watching the video where I interview him, and he just talks about being successful on the Nclex. It's an incredible interview. It's very, very encouraging, and it's worth your time if you're walking, driving, cooking, whatever you're doing. Just listen to it in the background. It's super helpful. We offer Nclex prep, a 21 plus hour Nclex online on-demand prep that also includes questions with it. You can get it for however many months you choose to purchase it for. We also have a streaming service where you can find all the videos that are on YouTube plus more. And then we also, plus more videos. And then we also have a small group tutoring. Go to clinicreviews.com and click on the on-demand option, I think. And you can go to the tutoring. You get 4 sessions for $200. And I do 2 of those sessions. So if you want to meet me live over Zoom, you can sign up for that. So let's go ahead and get started. These are some good questions, and I think you will like this video. All right, so before we start, because we're really talking about clinical reasoning, these are activities that require clinical reasoning, you do need to understand things very conceptually. So there's a lot of stuff here related to vital sign trends, and so I want to review this. So blood pressure equals heart rate times stroke volume times systemic vascular resistance. So what that means is that as heart rate goes up, blood pressure goes up. As heart rate goes down, blood pressure goes down. So the earliest symptom of a drop in blood pressure is tachycardia, because our body can stimulate the sympathetic nervous system, get that heart rate up, and get that blood pressure up. And so that's why the earliest symptom of hypotension or even shock is increased heart rate. And then you can see that increased stroke volume equals increased blood pressure. Okay, decreased stroke volume decreases blood pressure. So stroke volume is the amount of blood ejected with each contraction of the heart. The easiest way to increase stroke volume is to increase overall fluid volume, because if you have more fluid volume, you have increased stroke volume. So the easiest way for us as clinicians to increase blood pressure is to increase stroke volume, and we do that by giving fluids. That's why the earliest thing we usually do for dropping blood pressure is give them a bolus of normal saline, because that increases overall fluid volume. Now, if we know for sure that they're bleeding out, we can also give them blood, but we don't usually give blood unless we know for sure they're bleeding out. Like someone could be just dehydrated and we can give them fluids, okay? And then the other way that we can increase blood pressure is by increasing systemic vascular resistance. So that's the vasoconstricting the vessels. Now, we have to be very careful about vasoconstriction. So vasoconstriction versus vasodilation. Vasodilation is decreasing systemic vascular resistance. Vasoconstriction is increasing systemic vascular resistance. But we have to be careful, because when we cause vasoconstriction or we increase systemic vascular resistance, that it promotes blood flow to the major organs, but it decreases blood flow to the periphery, to the nose, to the ears, to the toes, and even the non-vital organs. So people who are on what we call vasopressors are medications that increase systemic vascular resistance by vasoconstricting. If we give vasopressors for very long, they can be actually necrose the nose, the ears, the toes. You can start to see kidney failure if we give vasopressors for too long. So these are just things that we have to be careful. That's why the first thing we do is give fluids. That's the easiest way for us to increase blood pressure, and the heart, the body itself is going to respond and try to compensate by increasing heart rate. Now, the body will also vasoconstrict, by the way. That's why when someone's going into shock, they become pale, right? Because the body's vasoconstricting to try to get blood to all the primary organs. All right, so let's start with questions. A client admitted with pneumonia has vital signs: temp 103.4, heart rate 122, respiratory rate 28, blood pressure 88/54, SpO2 86% on 4 liters. Which action should the nurse take first? So let's look at this, because when you have one patient with multiple objective problems, and these are all objective problems, what do you treat first? Okay, the only time you can use ABCs is when you have multiple objective problems that you have to choose between. Okay, so we have a temp, that's not ABCs, it's high, but it's not ABCs. We have a heart rate of 122, that's sort of ABCs, but we tend to think of ABCs as the C is usually blood pressure. So the blood pressure is low, so that's a big problem. Respiratory rate is 28, but the SpO2 is 86. So we have both A and airway breathing and circulation. That blood pressure is low, but because we can use ABCs, we actually address airway breathing first. So we're actually going to increase the oxygen to 6 liters. Now, we look at this and we say, well, they could be septic, so shouldn't we get blood cultures? Shouldn't we give the fluid bolus? Shouldn't we administer acetaminophen? I hope everybody knows administer acetaminophen would certainly not be first. But we don't obtain blood cultures first. We have to stabilize the patient before we do the blood culture. So I would increase the oxygen, then I would give fluids, and then I would draw the blood cultures. Do I want to give acetaminophen? I'm sure I do, but that's not my priority at this point. A post-op client's blood pressure trends, so we're doing vital sign trends, from 110/70 down to 92/60 over 2 hours. So that's a significant drop. The mean arterial pressure will have dropped, and the systolic is below 100. I'm always concerned when the systolic is below 100. Heart rate is increased from 88 to 124. So we see a blood pressure drop and the heart rate's gone up. So that's the body trying to compensate for these lower pressures. And then urine output has also gone down from 45 to 20. So we have a perfusion problem, right? We have a perfusion problem. Which complication should the nurse suspect? Well, I'm concerned about perfusion. So A is pain. That's not perfusion. Atelectasis. That's not perfusion. Shock. That is perfusion. When a patient goes into shock, they decrease perfusion. Urinary retention. There's no evidence of urinary retention based on the other symptoms. I mean, the urine output went down, but that's not enough for me to say urinary retention. I would be thinking more, if all I knew was the urinary output went down, honestly, I'd be more likely to think about decreased urine production rather than immediately think urinary retention. So anyway, it's a perfusion problem. And so shock is the only option here that says I know what a perfusion problem is. Because remember, blood moves from areas of high pressure to low pressure. The highest pressure should be in the arterial side of the body. So the arterial side of the body maintains a mean arterial pressure of 65 or above. And then the arterial or the venous pressure on the venous side tends to run between 20 and 40. Central venous pressure tends to run between 20 and 40. And so you got to keep the arterial pressure 65 or above so you can move blood through the body to the venous side. And when it moves from the arterial to the venous side, it goes through the capillary bed and releases oxygen and nutrients. So what my concern here is that the overall pressure, the arterial pressure is going down and the heart rate's gone up, which tells me the body's trying to compensate for it and it's not really helping. Who knows what the blood pressure would be if the heart rate hadn't gone up. And I have further evidence that this is a perfusion problem by the urinary output going down. Which of the following clients requires immediate assessment? So immediate assessment means they have a changing assessment, they have an unexpected finding, maybe they just were admitted. These are things that tells me they need an immediate assessment. COPD client with SpO2 of 93%. So that's not unexpected. 93 and above is considered within normal limits. So I actually would say, well, I'd expect them to be on the low end of within normal limits. So I'm not too worried about that. A post-CVA client with new slurred speech. So that's a changing assessment. I need to go in and see them. Diabetic client with a blood glucose of 68. So I wouldn't say it's unexpected until it's less than 60. I know we tend to, in the hospital, maybe, well, it depends on where you work. Where I've worked, we tend to be a little more aggressive when it's under 70. But for the Nclex, I would say if it's under 60, then it would be unexpected. Hypertensive client with a blood pressure of 168 over 92. Well, they're hypertensive, so they have hypertension. So that's not unexpected. So the only one that is really makes this patient unstable with a changing assessment is the CVA client with new slurred speech. The nurse monitors a client with pancreatitis. So pancreatitis is inflammation of the pancreas. There may be some infection there, but for sure there's inflammation. The inflammation may be caused by infection, I don't know. Has an elevated temp at 101.2, has an elevated heart rate at 118. The blood pressure is low at 90 over 56, and the respiratory rate is high at 28. What complication is developing? All right, let's see what we've got. Hypoglycemia. Well, there's no reason to think hypoglycemia. They're not a diabetic. They don't tell me what their blood glucose is, so I don't see that. Sepsis. Well, sepsis, for a person who's becoming septic, so in other words, an infection's getting into their blood, you see their temperature go up and their blood pressure go down and their heart rate go up. So that could certainly be it. These are things that could indicate sepsis. Fluid overload. Fluid overload, I would not expect their blood pressure to be that low, to be honest, and I wouldn't expect their temp to be high. There's no reason with a fluid overload for the temp to go up. Pulmonary embolism. I wouldn't expect a temp to be elevated with pulmonary embolism. Respiratory rate, I would expect it to be high, but I would expect also that there would be some new onset pain, so some chest pain. So that's also what I would expect. So the only one that really meets all of these symptoms is sepsis. Now, could it be something else? Sure, it could be something else, but it's asking you out of these four, which is it more likely to be? And I have to say the only one that meets all the criteria here is sepsis out of these four. A client on morphine PCA has a respiratory rate of 6, which is very low, and an SpO2 of 78%. What should the nurse do first? Stop the PCA pump, apply oxygen, administer naloxone, or call the rapid response team. Now, if you were to follow what I told you before, where I said address the symptoms first, then I would have to apply oxygen. The problem is they're telling us what's causing the problem, right? They're telling us that it's PCA morphine that's causing the problem. I mean, they didn't actually say that, but that's what we're supposed to recognize. So there's not much point in putting on oxygen when the PCA is still running and their respiratory rate is only 6. In fact, I would stop the PCA pump. I I don't know. I would probably administer Narcan, honestly, before I'd even apply oxygen because the respiratory rate is too low. But it's not asking me that, so that doesn't matter. I have to stop the PCA pump first. I have to stop it because what if I administer Narcan and then they're still getting morphine? Like, that's ridiculous. I apply oxygen, but they're still getting morphine. That's ridiculous. I call rapid response, but they're still getting morphine. That's ridiculous. I have to stop the cause of what's going on here. A septic client's mean arterial pressure decreases from 75 to 58. Now, remember I told you it should be 65 or above, despite fluids. So I was giving fluids and it's still low. In fact, it's lower than it was. Remember, in MAP, you can think of MAP like blood pressure. Now, blood pressure, you give two numbers, but MAP is still arterial pressure, and it should be 65 or above. So we have a low blood pressure. We have low arterial pressure. What is the nurse's next priority? I don't know. Let's see what our options are. Prepare vasopressor infusion, repeat fluid bolus, administer antipyretic. Antipyretic is for fever, increase oxygen flow. Well, we don't know what their O2 sat is, so there's no reason to give oxygen at this point. They don't have a fever. They haven't told me that. And I'm not going to read into this. I only know what they tell me. So I'm not going to do C or D. Now, the question is, should I repeat the fluid bolus, or is it time to do something different? So remember, blood pressure equals heart rate times stroke volume times vascular resistance. So we already increased stroke volume, and it's still going down. So really the next step is to increase systemic vascular resistance. And the way you do that is by giving a vasopressor. So that's what I'm going to do next. Now, in real life, you might say, well, the doctor always tells me to repeat the fluid bolus. That's fine. That's a preference, specific preference of that doctor. But what they're testing you on here is, do you know that if the fluid bolus doesn't work, what else can you do? So if you increase stroke volume and that didn't work, what can you do? Well, I can increase heart rate. No, we're not going to do that. That's not how that's not what we do unless they told us the heart rate was 40, right? If they told us the heart rate was 40, then I could do that. But they didn't tell us what that was. So the next option is to increase SVR. A client's vitals, heart rate 44, which is low, blood pressure, which is low. The patient is dizzy and pale. So it sounds like a perfusion problem. There's a perfusion problem. I don't know why. I have no idea why they have a perfusion problem. Which order should the nurse anticipate? Now, here we have a low heart rate, not a high heart rate. So remember, blood pressure equals heart rate times stroke volume times vascular resistance. So if heart rate goes up, blood pressure goes up. If heart rate goes down, blood pressure goes down. Do you know what this is? This is what's called symptomatic bradycardia. Symptomatic bradycardia. If they were bradycardic and their blood pressure was fine, like their MAP was still over 65, then I'd go, oh, well, maybe we're not going to treat it. Maybe we're not. But they're bradycardic and symptomatic. Their blood pressure's low and they're dizzy and pale. Now, remember I told you, oh, are we going to increase heart rate? The last question I said, well, why not increase heart rate? Because we didn't know what their heart rate was. Well, now we know what their heart rate is. So do you know what we're going to do here first? We're going to increase heart rate first. That's what we're going to do. So IV furosemide, that actually gets rid of fluids. That's not going to help. Morphine sulfate, that addresses pain and it vasodilates a little bit actually, so that's not going to help. Sublingual nitro, that's going to drop blood pressure. Atropine IV push is a anticholinergic, an anticholinergic that actually increases heart rate. So that is a drug you have to know. You have to know atropine is an anticholinergic and the drug of choice to treat symptomatic bradycardia. Which client requires the nurse's attention first? So this is, who do we see first? I got my dog right here. You can see his little nose. Hi, Israel. How you doing, buddy? Good boy. Yes, you're a good boy. All right. Which client requires the nurse's attention first? So we usually see the unstable patient first, but here all we have are vital signs. So can we determine who's unstable based on vital signs alone? Well, let's look. Post-surgical patient with a heart rate of 102 and a blood pressure of 132 over 82. So the blood pressure is perfectly fine. The heart rate is slightly elevated. So they have one abnormal vital sign. Post-surgical patient with a heart rate of 58, the heart rate's low, and the blood pressure is also low, 88 over 54. So both of their vital signs are abnormally low. Post-surgical patient with a heart rate of 110 and a blood pressure of 102/65. So again, the heart rate, I usually you don't see an elevated heart rate as particularly symptomatic until it gets over like 120, 130. So it could, with the post-surgical patient, they could be having pain, that heart rate of 110. Like if it was 135, I'd be like, oh, that's too fast. Here we got 110. I mean, they do have 2 abnormal vital signs, so we're still going to keep it on the list. Post-surgical patient with a heart rate of, no, they don't. I'm sorry. C does not have 2 abnormal vital signs. It has 1 because the blood pressure is normal still. And if you did a map, both the map is fine and the systolic is above 100. So that blood pressure is fine. Sorry about that. It's only the heart rate that's up. D, the post-surgical patient with a heart rate of 54, that's low, and a BP that's normal. So there's only one patient here actually who has both an abnormal heart rate and abnormal blood pressure, and that's the one that I'm going to pick. So do I usually count the number of risk factors? For who do I see first? No, I don't usually count the number of risk factors or abnormal findings for who do I see first. I never do that. But what I want to show you is that every question is not going to be the same, right? So when it says who are you going to see first, it's not necessarily going to give you a big, long, complicated 4 patients. It could just give you heart rate and blood pressure. Well, now what do I do? Well, then who's got the most abnormal stuff? Like this is the only patient who has 2 abnormal vital signs, so we're going to pick that patient. The nurse reviews vitals for a post-CABG client, temp of 100.8, which is slightly elevated. Heart rate is 112, that's elevated. Blood pressure is 110/64, that's fine. Respiratory rate of 26, that's elevated. So the temp, the heart rate, and the respiratory rate are all outside normal limits. Which action is most important? They're post-CABG, that's open heart surgery. Recheck vital signs in 30 minutes. I don't feel real comfortable with that because this is a post-CABG patient. I don't like A. Administer scheduled beta blocker. Maybe that addresses the elevated heart rate. It doesn't do anything about the temp or the respiratory rate. Provide pain medication. It could be pain. It could be pain. That could be why the respiratory rate and heart rate's up, but it doesn't address the elevated temperature. Assess the surgical site for infection or bleeding. Okay, that's the answer I'm going to pick, and I'll tell you why. None of the answers address all of the problems, and I don't really know what the problem is. It could be pain. It could be they need their beta blocker. It could be that they have bleeding at their incision site, like they're just post-CABG. So if I don't have enough information to take action, and I really don't have enough information yet to take action because their blood pressure's fine. It's just their heart rate's a little up. Their temp is a little up. Like it's not that high up though, right? Respiratory rate, these vital signs are not that outside normal limits, but they are outside normal limits. So I do need to at least assess something, okay? So I'm going to assess the incision surgical site, and then I may decide to give pain medicine or beta blocker. I may decide after I do that to do one of those things. A client with cirrhosis has a heart rate of 122, which is high, and a blood pressure of 82/48, which is low, and vomiting blood. Well, that's bad. What is the nurse's first priority? All right, cirrhosis. So one of the risk factors is hemorrhage. A lot of people with cirrhosis die from hemorrhage. And so I am concerned about this. I'm concerned that they're bleeding out. So what is the nurse's first priority? Start IV fluids. Well, that's one way to address that low blood pressure. Insert an NG tube. I would probably want to do that, but that's not going to stabilize them at this point. Administer antiemetic. I probably want to do that, but that's not necessarily going to stabilize their blood pressure. Monitor abdominal girth. I'm probably going to want to do that, but that's not going to stabilize anything. I need to address the abnormal objective finding and stabilize this client. The best way to do that is to give IV fluids to try to get that blood pressure up. So that is the correct answer. Now, will I probably give blood as well? I probably will. But that's right away. My first priority is to start IV fluids. All right, client's vital sign trends. Heart rate went from 88 to 110 to 124. I don't know the time frame, so we just have to look at the numbers and not ask ourselves what's the time frame. The numbers alone should tell us the answer. So the heart rate's going up outside normal limits, blood pressure's going down outside normal limits, and the urine output drops to 15 mils per hour. So it should be 30 mils per hour. What is happening? Worsening dehydration. That could be it. It could be worsening dehydration. It's a perfusion problem, and dehydration can cause that. So that may be it. Pain response. Pain response, I'd expect the heart rate to go up with pain, but not the blood pressure to go down. And I certainly wouldn't expect the urine output to go down with pain response. Hypertensive crisis, the blood pressure goes up, not down. Shock progression. All right, shock progression. So shock, there's lots of different kinds of shock. All of them, shock means essentially a low blood pressure, right? And it's a perfusion problem. That's what shock is. It could be shock as a result of dehydration. But do you know that D is more of an umbrella answer over A? A is very specific. It's saying it's dehydration, whereas D is just saying some kind of shock. And I like that answer much better because I don't know what the issue is. It could be cardiogenic shock, which is not a dehydration problem. Okay, so I don't know. I just know that it's some kind of shock with that blood pressure dropping like that. A client on IV heparin develops sudden flank pain and blood pressure 86/50. Which complication is suspected? So flank pain is over the kidneys. Okay, it doesn't say which side, but flank pain is over the kidneys on the lower back. Pulmonary embolism. Okay, pulmonary embolism usually results in chest pain, not flank pain. Internal hemorrhage. It could be that. Flank pain. So pain and dropping blood pressure, it could be internal hemorrhage. I mean, it's pretty vague, but it could be kidney stone. All right, flank pain with kidney stone, yes, but the blood pressure should not go down with a kidney stone. Myocardial infarction. I mean, flank pain is not common. It's chest pain usually. So if we want to choose something that it could be, because all the others, like pulmonary embolism doesn't have the classic symptom, which is chest pain. D, myocardial infarction, doesn't have the classic symptom, which is chest pain. So I'm ruling those out. So really I have to choose between internal hemorrhage or kidney stone. And the reason I'm going with internal hemorrhage is because the blood pressure is dropping. You would not expect to see a blood pressure drop with kidney stone. So they could be having bleeding in their kidney. Okay, so the flank pain could tell us they're having bleeding in the kidney, which is internal. And they could have a kidney stone that's causing it. But I'm still more concerned about the hemorrhage than the pain itself. Which assessment finding in a client receiving IV nitroprusside requires immediate intervention? Remember, IV nitroprusside is a vasodilator. It actually decreases blood pressure. Okay, it's used for hypertensive crisis. So it decreases blood pressure. So, which requires immediate intervention? Headache. Well, headache is a side effect of nitroprusside. Flushing. Let's see, if we vasodilate, it wouldn't be that surprising to me if we flush in the face a little bit. That actually sounds like a side effect to me. Blood pressure of 88/50. That's too low, y'all. That requires immediate intervention. I don't want the blood pressure to be that low. Usually we keep systolic over 90 or over 100 depending on the doc, or they may just give a map of 65. But anyway, we don't have a parameters here, so I just have to say that's definitely too low. Nausea, probably a side effect. Vasodilate is probably going to be somewhat of nausea is like a side effect of every medication. I swear it is. I would never consider nausea to be something that requires immediate intervention unless it's like new onset and they tell me it's the only one that has something new going on. So I'm going to choose the blood pressure of 88/50. Remember, vasopressors like dobutamine, those vasoconstrict and increase blood pressure. But nitroprusside is a vasodilator. It's not a vasopressor. It's a vasodilator, and it decreases blood pressure. So make sure you know the difference between those. Which client's vital signs indicate the greatest risk of deterioration? Deterioration. All right. A, heart rate 56. So heart rate is low. Blood pressure's high normal. It's actually considered hypertension. The 140 is considered hypertension. And the temp is up. So we have heart rate's abnormal, BP's high, and temp is high. 2, or B, heart rate is 126, that's quite high. Blood pressure's low, 88/56, and the temp is quite high at 102.4. C, heart rate is 60, which is normal. Blood pressure is 128/76, which is normal, and the temp is 98.2, which is normal. D, so I'm crossing off C. D, heart rate's 92, which is normal. Blood pressure 112/70, which is normal. And the temp is 99.5, which is normal. I would go up to about 99.9 as normal. There's a lot of people that tend to run high like that. So I'm saying C and D are both normal. I'm crossing them off. So I have two abnormals. I have A, whose heart rate is a little slow, but the blood pressure is slightly high and the temp is slightly high, versus B, who has a very high heart rate, a very low blood pressure, and a very high temp. So I'm very concerned that B could be going into septic shock. A, to be honest, they're stable. I might want to do some, I don't know, it doesn't tell me what's going on. So if they have a slightly elevated temp like that, I might be like, let's do some coughing and deep breathing. I don't know why it's high like that. Maybe I'd get a urinalysis to see if they have a urinary tract infection. But B is symptomatic. That looks like this is going into sepsis to me. All right. That was a lot. That wasn't easy. I hope that you found that helpful to kind of review vital sign trends. That's really what we're focusing on. A little bit on complications, but we're really focusing on vital sign trends today. And I hope this is helpful. Again, we are primarily an Nclex prep channel. These strategies are going to help you pass your Nclex. They can also help you on any of the standardized tests that you still need to take in school. So have a great rest of your day. Thank you for being a part of the Clinic Review family.